and Pain Relief at Kidwai Memorial Institute of Oncology. Please welcome Dr. Arati BH to speak on anesthesia versus cancer, the recurrence riddle.
This one, not
Very good afternoon, everyone. I know we have come to the end of the day with a brainstorming topic that is the riddle, the ongoing, the trending research topic of onco anesthesia as well as onco surgery. The recurrence, is it due to the anesthesia? That is the trending topic which is going on. So to keep you all awake, I think scientific committee has kept it at the end so that you scratch your brains at the end. So greetings from my institute, Kidwai Memorial Institute of Oncology. So actually with the International Agency of Research on Cancer, a branch of WHO, they have shown that incidence of cancer is in increasing trend. They say by end of 2030, the cancer is going to be around 22 millions, and by end of 2040, it can go up to 28.4 millions. And WHO, when they assess the mortality rate in 2015, they say the mortality with the cancer is almost one-sixth of all the global deaths. With this, the burden of cancer is increasing in society. How it is impacting us? It is impacting on patient, it is impacting on financial state of the patient, it is impacting on caregivers, the society, the death rate is increasing. With this, the research of the cancer recurrence, is it the causes of cancer recurrence, where is it associated, has started. Let us know what is, before knowing this, what is cancer metastasis. Cancer metastasis is nothing. When the tumor breaks down, the cells gets into the circulation and grows in another site. How it is done, I will tell you later. And what is cancer recurrence, how it is different from metastasis. Recurrence is nothing. When patient has some time of disease-free state, and then again the disease comes, then it is called recurrence. It can be a metastasis or a local regional growing of the disease. So this is how the cancer grows. If you see in this picture, the cancer cells from the tumor gets evasion from the tumor and gets into the circulation. Gets into the circulation, and then from there it travels and gets out of the circulation. Pointer. Here, if you can see here, the cancer cells from this, it gets into the circulation, gets out of the circulation some other point, and gets into some tissues, and it starts growing as a micrometastasis. With the micrometastasis, the tumor growth factors will be proliferated. There is a growth of new vessels, which again causes the metastasis. This is the fundamental way how the cancer metastasis can happen. So now what are the effects of surgery on cancer? One is direct. With all this we understand, it can just by cancer surgical tumor manipulations, it can release the cancer cell into the bloodstream, and it can cause a distant metastasis. Or it is an intraperitoneal seeding called transcelomic spread. Or because of an increased hydrostatic or oncotic pressure, the cancer cells can get disseminated tumor cells through the lymphatic circulation. So these are the common way we can think of how the tumor can spread into the other tissues and cause metastasis. The only thing what we should do, the metastatic tumor, the histopathology will be same as the primary tumors. This is the indirect way or a physiological effect of surgery. When the patient has a neuroendocrinal response, patient has increased cortisol, increased ketamines, which will again help in tumor growth factors, and the cancer tumor can grow again as a metastasis. Or the inflammatory response, which will cause immunosuppression, which will have decreases the natural killer cells and increases the tumor growth factors, causes the cancer metastasis. These are the hypothetic how it can cancer can metastasize. And surgical stress factor also can induce the sympathetic nervous system, which will help the growth of the cancer cells. So overall, in summary, if you can see, the tumor can, early cancer can be detected, and then the angiogenesis, inflammation can all progress the tumor or allow the tumor to grow in a different metastasis. Whereas the immuno and the stress of surgery and anesthesia with the inflammation, immunosuppression, hypoxia, that is tissue hypoxia, and then tumor growth factors and angiogenesis, all that will make the tumor grow into a bigger size or as a local recurrence, or it can travel through the blood or the lymphatic system to another site to cause metastasis. So what is anesthesia role now? We are talking about surgery till now, how anesthesia is going to cause recurrence. It will modulate the immune system activity, alter the systemic inflammation response, and then it will affect the neuroendocrine stress pathways. It will even interfere the cancer cell signaling mechanism. With all this, will suppress the immunity, so that immunosuppression causes inflammation, so that our natural killer activity will be reduced and increase the production of tumor growth factors and the local recurrence and metastasis. What are the two anesthetic techniques which is in favor of reducing the anesthesia recurrence or metastasis? One is TIVA. TIVA is propofol-based. TIVA has an anti-tumor effect if the opioid used along with this. And the mechanism is it inhibits the COX-2 inhibitors and preserves the natural killer cells, which is very important for metastasis not to happen. The other technique is regional anesthesia. As we all know, local anesthetics has anti-inflammatory properties, and regional anesthesia reduces the stress response, so immunosuppression is reduced. So these are the two techniques which is proved to be beneficial in reducing the metastasis and recurrence. These are the various drugs and its impacts, which will be told. So in this, let's see which are the important drugs which is going to affect the cancer recurrence. One is propofol. They say propofol, it is to some extent proved that propofol is safe in oncoanesthesia because it is stress-induced, reduces the stress-induced immunomodulation. Whereas our thiopentone, the famous popular thiopentone and ketamine, are not user-friendly in oncoanesthesia as it inhibits the, helps the natural killer cells to progress, inhibits the natural killer cells and apoptosis. Volatile anesthetic is again tumorogenic and it is immunosuppressant. When it comes to opioids, it is again increases angiogenesis. We do not want angiogenesis or new vessels to happen. Again, it helps in recurrence or it causes recurrence. Lignocaine, as I told you already, it will help in reducing the recurrence. NSAIDs, alpha-2 blockers, the NSAIDs is anti-angiogenic, so it helps in reducing the recurrence. And if you see all the steroids and this midazolam has still yet to be proved what is the effect of the midazolam on the cancer recurrence. If you see in opioids, all the opioids suppress the natural killer activity, which is again says that it does not help in reducing the cancer recurrence. So when we see the comparison between TIVA and volatile, TIVA decreases hypoxic-induced fractions and exhibits antioxidant and anti-inflammatory property. There's one landmark study by Wigmore et al. They did a retrospective study on 7,000 patients, which improved a survival rate of 22.5%, whereas volatile anesthetics had a survival rate of only 15.6%. This is the study. There is various studies. If you see that there are various studies, but all of them are retrospective studies. There's yet to come a lot of studies. These are all inconclusive. Some says TIVA is beneficial in reducing the cancer recurrence. Some says there is less of overall survival. So overall, there's still more lot to come on the studies. But till now, whatever we have got, the research, it says propofol is beneficial. This is how every conference we have a topic on cancer with recurrence. As I told you, local anesthetics also beneficial in. These are the various studies with local anesthetic and GA. With the studies, we still have not completely inconclusive, which says local anesthetic with general anesthesia is going to be benefit in patients who's going to have metastasis. So with all this, what we understand, there is a surgical stress which causes immunosuppression, inflammation, angiogenesis, and tumor growth factors, which will cause of the growth of the tumor as a local recurrence or a metastasis. For this to accentuate these activities, opioids, inhalations, and steroids will help the tumor to grow or increase the immunosuppression tumor growth factors so that the chances of metastasis increased. Whereas our regional anesthesia, local anesthetic, TIVA-based, propofol-based TIVA and NSAIDs are beneficial in reducing the tumor recurrence. The other factors other than the drugs and your technique, temperature, hypothermia, even the mild hypothermia is immunosuppressive. As we have understood till now, immunosuppressive is not beneficial in onco-anesthesia. And your transfusion of blood, that is stream, transfusion-related immunomodulation can cause tumor recurrence. There are some concepts are upcoming concepts in onco-anesthesia to reduce the duration of the treatment so that patient does not have metastasis or recurrence. One among them such concept is RIOT, the return to intended oncological treatment. Nowadays, this is used as an end point to assess the quality of the cancer care. What is RIOT? Here, you have to take care of the patient in such a way patients gets into the another mode of the treatment as early as possible. Invariably, cancer patients will have to undergo multimodal treatment. It is chemotherapy, surgery, followed by chemotherapy. So the duration between the surgery and chemotherapy should be reduced as much as possible so that patient has a more disease-free interval. So what are the strategies to improve RIOT? We already learned from the previous speaker, that is adapting prehabilitation, where patient is actively involved in taking care of their nutrition, exercise, psychological support, multidisciplinary approach, enhanced recovery programs, that is very, very, very famous is ERAS protocols, minimally invasive surgery, and optimizing the perioperative care. So now what is ERAS? ERAS is nothing but a protocolized scientific, evidence-based scientific pathway. So it is applied in each phase of the surgery, preoperative, intraoperative, postoperative, and including rehabilitation, so that patient is recovered as early as possible to go for the next modality of treatment. If you can see here, patient is actively involved in, patient has been taken care preoperatively, intraoperatively, and postoperatively, using all the modalities. Goal-directed fluid therapies, minimal invasive surgeries are introduced so that patient is early ambulated and recovers fast for the next modality of treatment. So what is the future in? There are newer trends are coming in on onco-anesthesia. It can be personalized anesthesia, integration of technology, immunomodulation. There are various ways of technology are coming in future. But yet we are inconclusive on which is the thing which has to be avoided to avoid recurrence in anesthesia. A lot of projects and prospective studies have to be done to come to a conclusion on. So what's your take-home message? The optimal anesthetic for individual with cancer would be diminish the sympathetic response while ensuring sufficient tissue perfusion to prevent tissue hypoxia. Mitigate the pro-inflammatory environment while preserving appropriate healing response. Regulate the release of cytokines and cellular function to promote enhanced activity and NK cells. The oxygenation has to be maintained at 0.4. Hypoxia will increase the tissue growth factor, and hyperoxia is again, which will help in depressing the natural killer cells. To conclude, anesthetic techniques may influence cancer progression beyond the perioperative period. Perioperative intervention can affect long-term cancer outcomes. Inhalation agents and opioid-based anesthesia may negatively impact cancer outcomes, while propofol, TIVA, and regional techniques may be protective. Decision on anesthesia approach should be patient-specific, weighing the risk and benefits. These are my references. Thank you.
Thank you, ma'am, for that thought-provoking session on how anesthetic technique might influence long-term oncological outcomes.
We now open the floor for discussion.
anybody is awake to ask questions. So kept it last. Who will listen to oncology?
It's a nice topic, sir. And how the anesthesiologist can help in prevention of this thing, metastasis or
Recurrence.
recurrence in cancer patients. Madam has dealt very nicely. Thank you, madam. Thank you, sir. And these cancer patients are going to increase day by day, and cancer hospitals are also increasing. We need to learn about the HIPEC techniques and anesthesia management in HIPEC technique. Thank you, sir. Thank you.
If there is no questions, we'll conclude.
We now request the chairpersons, Dr. Suresh Baivi, to present memento to Dr. V. Arun. And Dr. Mallikarjun to present the memento to Dr. Arati BH. Now we invite Dr. Sunny Cope, past President ISA Karnataka, to kindly present mementos to our chairpersons, Dr. Suresh and Dr. Mallikarjun.
With this, we conclude the scientific sessions for the day. Gentle reminder to PG delegates that the ISA Mangaluru Namakudla quiz will be starting at 5 p.m. in Hall B. Up next, we have the annual general body meeting of the ISA Karnataka chapter here in Hall A, starting shortly.